I appreciate the invitation to attend. I've chosen to use this kind of microphone because I'm one of the rovers. I can't stand still for very long, so I'll be back and forth, I'm sure, across the room. This is a very personal topic, and many of you will often have your own anecdotes to add to my discussion, and I wouldn't be at all hurt if you wanted to move closer in the room so that I can have a better view of your faces and see how you're responding to my talk. To start by saying that as a physician I have had 20+ years experience of dealing with patients who die. And as a student, I used to think that death was a failure on my part. It took me a number of years, actually, before I began to realize that death was a natural event, because I think that I was conditioned from my medical school experience to believe that when I lost the battle, when St. Peter won the tug-of-war, that I had somehow or other failed. And I think it's in maturing into a more, I hope, caring and compassionate physician that I've come to recognize that death is inevitable, and that my task is not to prolong death, but rather to assist in the ending of a dignified and gracious life. Now, many patients have the luxury, and I call it a luxury, of preparing for their death. Those are the lucky ones. The patients who know that they're going to die either because they have cancer or they have some kind of irreversible neurological disease, because they have time to make peace with their family, make peace with their world, and make peace with their God. You have time as well to work with the family so that they can come to understand what this experience is going to involve. And in many instances, the grieving can be accomplished while the patient is still alive, and the family have all kinds of support systems to help them through that process. My concern and my fear is that the support systems often disappear very quickly once the patient has died. And that's why I think that in many respects, having a chance to prepare for death is a bit of a luxury. When there are children involved, that's also a very valuable time. I think personally the reason that I'm so interested in this topic is because my own father died at the age of 13, when I was 13 rather. He wasn't 13, I was. And I know that he was not told that he was going to die, even though it was obvious to everyone else. And he deluded himself, I think, into believing that he was going to survive, and as a consequence left life with no preparation. He had not had a chance to make peace with his world or make peace with his God. He hadn't even had a chance to get his business affairs in order. And the chaos that that created for the next 5 years of my life stands out so clearly that I was determined from that point forward that if I had anything further to do with patients who were dying, I would never let anyone go into death the way my father did. I don't have any sense of vindictiveness against the physicians who were involved. I simply feel that that was not the way that a gentleman of considerable intelligence and tremendous dignity should have been allowed to exit his life. Now, the patients who, or at least the families, I think, who have the most difficulty are those who are faced with a sudden death, because you have no time to prepare. Nothing is ready. The woman is contacted in the home because the husband has been killed in an industrial accident, or the family is contacted because the teenager was killed in a car accident coming home from the party at night, or the family finds when they arrive at the hospital that father died of an acute heart attack at the age of 42, 10 minutes before they got there. And there's no time to prepare. There's no opportunity to say goodbye, and oftentimes there's very little in the way of support systems, and I'm going to re-emphasize that as we go on in this talk. Somebody may rally and come to the hospital to escort the family home, and there will be people that are around for the funeral, but they evaporate very quickly, and the support systems are essentially gone within a matter of days. So that the family of someone who's dying very quickly is oftentimes left bereft in more than just the physical sense, but also in a support an emotional, and even a spiritual sense.
Excuse me. Can you folk hear down there?
Yeah. It's on.
It's on, is it?
Yeah. Yeah. Now, I'd like to come back and concentrate on the patient who has an opportunity to prepare. The patient who goes through everything that modern medicine has to offer these days, and spend quite a bit of time talking about that. Talk a little bit about the ethics involved in some of the decision-making in medicine. Talk a bit about the support systems that are available. And then talk a little bit about what the roles might be of you and I in all of this process. I think most of you are appreciative. You only have to watch TV shows that involve physicians to recognize that the medical technology that we have available to us today is absolutely incredible. It is now possible to keep someone such as Karen Ann Quinlan, for example, alive for 10, 20, 30, 40 years. We haven't gone that far yet, but we certainly have gone well in excess of 10 years of someone who has no functions compatible with life as you and I know it. I have personal experience with a 44-year-old woman who had a cardiac arrest at home on November the 12th, 1979, has EEG or electroencephalographic activity, so is not dead in the legal sense of the word, but has had no interaction with the external world since that time. She is still alive. She was supported by respirators and ventilators for the first 6 or so months after the event occurred, and then after a rather prolonged and bitter court battle, these were withdrawn. And today the only form of life support that she has is a tube into her stomach that gives her liquid food, the same sort of stuff that you get in Carnation Instant Breakfast. But she is the healthiest person that I know at this time who is 55 years old, except that she doesn't have any interaction at all with the rest of the world. She is dead by the criteria that we would have used in the Victorian era, but she is alive by the criteria that we are required to use in this day and age. She has never had pneumonia. She has never had a bed sore. She has gained weight, and she looks as healthy as anybody in this room. And I think that's one of the examples of what modern medicine is able to do these days. And the problems that we get into is separating out what we are capable of doing, what we are supposed to do, and what we should do. And I use those words very carefully because I think that ethics, and this isn't unique to me, I've stolen this from someone else, is the study of how people ought to behave, that social sciences are the study of how people do behave, and the law is the study of how people are permitted to behave. And the problem is that all three of those are getting mixed up in the decision-making these days, and much what used to be, I thought, very clear has in fact become much murkier. So that we're faced in the hospital environment now with patients such as the one I've just described, who by most criteria has no meaningful existence, but according to the law is alive. And the dilemmas that creates are terrific. She has a husband who cannot collect on her life insurance, which is desperately needed in order to educate the small children that she left at home. She has a husband who's not legally able to enter into any other relationship because he is legally bound to this woman, and who feels, and I give him credit for this, that it would be disloyal to divorce her for the purposes of entering into another relationship. And she has a family who cannot grasp that there is not a miracle lying around the corner that's going to make a drastic difference to the way she is functioning in 1989, or for that matter in 1979. And these kinds of dilemmas are facing us increasingly frequently in medicine. There have been times when every bed in the intensive care unit at the Victoria General Hospital was occupied by a patient who had no optimism, no hope at all of any kind of recovery. But because they were being supported on life support mechanisms, they had to be nursed there because that was where the complement of nurses was appropriate to care for that kind of patient. What that essentially means then is that someone who has got a hopeful prognosis and who requires that kind of support actually can't enter into the system because there is no place for them. Those beds, that equipment is already being utilized. So decision-making these days is very complex. It is caught up in our ethical understanding, our moral and personal persuasions, and the limits of the law. And they are not necessarily all moving in the same direction. Now let's look at some of the factors or some of the ethical considerations that have to go into decision-making. I think there are two basic principles when it comes to ethical decision-making. The first is that whatever decision is made must be universal. In other words, all similar cases should be treated similarly. And the second principle is that the choices made must be consistent and they must be complete. That is, they must fit with all of the pieces of the puzzle. And that means that decision-making cannot be done quickly. A lot of thought must go into it. All of the factors, all of the values that have to be considered must come forward for discussion. That's one of the reasons why almost every hospital in the province, in some fashion or another, now has an ethics committee, which can be employed to consider difficult cases such as the one I've just described, and to make sure that all factors are being considered, and that decision-making is not being done on one individual's personal whim or one family's conflicts, if you like, or guilt. Now, the values that have to be considered then in ethical decision-making are, first of all, that of personal autonomy, the right of the individual to make their own decisions. Secondly, the sanctity of life, which I think everyone has a universal agreement on. Thirdly, the word that I always have difficulty pronouncing, beneficence, which I think really means fairness to all. That is, we must respect or must at least uphold the well-being of the individual. And fourthly, the freedom of choice. Now, these sound marvelous. They sound a little bit like the Ten Commandments. They should be extremely easy to put into play. But they're not really. And the reasons are a whole pile of factors. First of all, the medical profession has a long history of, I'm going to use a very sexist word, but there isn't any other word for it, paternalism. There has been a feeling for many years, still shared by some of my colleagues and a lot of my older colleagues, that the doctor knows what's right. And the number of heads nodding in the room would suggest that you've experienced this yourselves. And that, if you had to look at one revolution that's occurred in medicine in the last 20 years, I think the thing that has shocked us almost to the foundations is the recognition that that's not correct. It's not ethically acceptable. It's not legally acceptable. It is simply not the right way for us to function as physicians. So what we're having to do these days, and many people are struggling very hard with it, is shared decision-making with the patient. The doctor does not always know what is right. He certainly does not know what's right for this particular patient. And I'm going to be totally non-sexist, so I'll change the pronoun. She certainly does not know what is right for this family. So we have moved into what has become a very legalistic situation where the patient must not only consent to what is being done by the doctor, but must provide informed consent for every aspect of medical care. And I can tell you that in the last year, I can think of no other issue that has preoccupied more of my time than the question of informed consent. Because we all accept, we being the medical profession, that patients must consent to what we do, but the process of consent has become a very contentious one. In the United States, they've dealt with it by producing 4-page legalistic documents which patients must sign every time someone even approaches them with a needle to take blood. And I think that's totally incorrect. I can't understand those forms. I certainly don't expect 99% of my patients to be able to either. In Canada, we've gone the opposite extreme. We've produced a very loosely worded document present in many hospital charts that simply says, I agree to anything the doctor wants to do. Well, that just reinforces paternalism. And I'm sure that any of you who've been in hospital in the last little while have seen such a consent. You may not even have read it because it only had 4 or 5 lines on it. And you basically signed away your right to make decisions, theoretically. The reason I say theoretically is because the courts of law in Canada are no longer accepting that. They're saying that the patient must give consent and that the physician must record not on the consent form but in the notes what the discussion involved. In other words, the process must be documented. Hospitals, unfortunately, are often run by lay people. Not unfortunately, fortunately, are often run by lay people. And they want, though, these legalistic forms on the chart. So the wrangling that goes on right now is between hospital administrators and those responsible for carrying out the healthcare system about what the nature of informed consent should take. Now, why is that important? Well, it's important at a basic level. Obviously, if someone's going for an operation, they need to know what this operation will involve. If they've got cancer and they're going to receive highly toxic drugs, they need to be informed about what the consequences of those drugs is going to be. And if they have the right to make consents about those kinds of issues, then they have the right to make consent or give consent about whether or not they want to be supported by things like ventilators when that time comes as well. And although we're being very careful in assuring that we get consents when people go for operations, and reasonably careful in getting consents before patients have chemotherapeutic agents, we're often caught when the moment comes to make a decision to intubate a patient and put them on a ventilator, for example, or to institute cardiac resuscitation techniques, so-called CPR. There isn't time to ask at those moments. There isn't time to say to the husband or the wife, even the brief sentence, what do you think your spouse would have wanted us to do? Because you have about 2 minutes to get that person resuscitated. After that time, the damage is already begun in the brain cells. So you cannot be making critical decisions when critical actions are necessary. Sometimes, even when resuscitation occurs within that very narrow window, the outcome is not always favorable. And current statistics suggest that somewhere between 15% and 30% of all patients who are resuscitated actually survive, and about 10% survive in the same form that they were before the resuscitation took place. So it's a pretty bleak situation that you're facing. Now, the reason why I bring this up is because although it has no binding form in law, in other words, the legal profession don't accept it, physicians are becoming increasingly interested in having patients look at the concept of a living will. Now, I don't know how many of you even know what a living will is, but I'd ask you to give some thought to it, first of all, on a personal level, secondly, with members of your family, and thirdly, with members of your own congregations, if the opportunity presents itself. A living will is a document that indicates you have thought long and hard about what you want when your time comes. So, for example, if you have considered what you would like to have done in the event that you're so severely injured that you can't make your own decisions, it would be useful to have that on a piece of paper. It is not legally binding. I want to reiterate that. The legal profession does not regard this as legally binding. Anyone who's the next of kin and has the legal right to do so can reverse whatever you've written on your living will if the moment presents itself and they're allowed to. Let me give you an example. About 20 years ago now, I was dealing with a very intelligent patient who had a terminal illness and who developed a bleed into his head. And we, for a whole host of reasons, were trying to determine if there was anything further that we could do, and we did a test which we knew had significant risk associated with it. And he was not capable of making the decision any longer himself, so we spoke to his wife, and she insisted that we did the test, and we did. And the end result proved to be a fatal one. But he was on a ventilator at the time, and he had in his wallet a card that made it very clear that in the event something like this happened to him, he wanted the ventilator discontinued. It could not, I've never seen anyone state that so clearly as was stated in this man's wallet. But his wife and he had never discussed this, and she was petrified. And she overturned his decision and insisted that we maintain him on a ventilator. And he was maintained in that situation for 6 weeks before nature finally took him on its own. Now, 6 weeks may not be a big deal, and he wasn't really conscious, so maybe it didn't matter to him. But it's very difficult, I think, as a physician, to spend time for 6 weeks caring for a patient that you know is being treated in a way that he did not want to be treated. I'm not arguing with the wife. I don't think she had any other alternative. She was grief-stricken, very upset, and they had never discussed this issue. But I think you have to give some thought about whether or not you'd want to be caught in the same situation. Because I couldn't reassure you enough that medicine can keep the body going long after the mind is no longer capable of functioning. And one of the provocative things that I want to leave you with here today, if I accomplish nothing else, is to ask you to personalize what I'm saying. Ask you to ask yourself what you want done. Because I don't think it's possible for any of us to go and counsel patients, either as a physician or as a pastoral care worker, without coming to grips with how we feel about some of these topics ourselves. I think that's vitally important to our ability to work closely with these people. Because unless we have personalized it, we really are always functioning not as a sympathy giver, not as a supporter, but rather as an intellectual. Another dilemma that I think physicians face from an ethical point of view is when and what to tell the patient. I've already indicated to you that I am not happy with the way my own father was treated. With tongue-in-cheek, I'll tell you that I don't know how many of you subscribe to Newsweek, but Newsweek came last night, and while I was eating breakfast this morning, I was reading Nancy Reagan's memoirs that are in this week's Newsweek. And I noted that when Ronnie Reagan was found to have a malignant polyp in his bowel, she insisted that the doctors not tell him. And he found out by reading the newspaper. I can't imagine a worse way to find out that you've got a potentially fatal disease. And I think that many of us as physicians are afraid to tell patients what's going on. And we get swayed by the wishes of the spouse. And this is a topic I feel very strongly about. I think if I respect the patient's right to autonomy, I think I must respect the patient's right to know. And I must give you an interesting anecdote that happened to me, which I hope will make you smile, although I must admit at the time it was a rather embarrassing one for me. I had a marvelous patient a number of years ago. He was 84 years old, and he was admitted to the hospital for his second course of chemotherapy for a form of chronic leukemia. Leukemia has an awful sound to it, but there are forms of chronic leukemia that can go on for years. And he had one of these forms. So in fact, it was unlikely that his lifespan was going to be dramatically shortened, but it was going to be uncomfortable, and for that reason the physicians had chosen to give him chemotherapy. And I realized that the first time he'd had chemotherapy, he'd never been told about it, so I felt it was my responsibility to make sure he at least understood what the consequences of the chemotherapy were. And I went to his room to do this. Now, the other thing that was notable on his chart was that he had a test that was positive called a VDRL. Now, a VDRL test is a test for syphilis. That wasn't a big deal. I mean, he obviously had no complications or symptoms of it, and basically the way we treat a test like this is just to give the patient a course of penicillin. So as an incidental thing, when I went to tell him about the chemotherapy, which to me was a very big issue, I just told him that we found that he'd had syphilis and we were going to give him a course of penicillin. And I left the ward and went home, documented it all very neatly on the chart, went home. 4 o'clock in the morning, I get a call from the Anglican clergyman at the hospital. Would I please come in and undo this horrible mess I had created? Well, I hauled on a pair of blue jeans and raced down to the hospital and thought I should never have told him about the chemotherapy. He just couldn't cope with it. I should have just left well enough alone. That was obviously why the original physician had not made that choice. I get into the hospital and there's a distraught 84-year-old man just tearing the ward apart. And no one can cope with him. The nurses can't deal with him. The clergy couldn't deal with him. I go up to him and I said, "What's the matter?" And he looked at me and I said, "What did I tell you about the chemotherapy that upset you so much?" He said, "The chemotherapy?" He said, "What am I going to tell my wife about syphilis?" He said, "I even know when I got it. It was 1918 in France. It was the only time in our entire 62 years of marriage," he said. So I learned a lesson then about what I should tell patients. I make sure now that I place equal weighting on everything I tell them, even what seems to me to be incidental, because what's incidental to me is not necessarily incidental to the patient. But I do think it's important that the patient has a right to know. If one of the ethical values is that the patient's autonomy needs to be respected, it can't be respected if we're hiding part of the problem from them. And one of the reasons that I originally got involved in this aspect of the medical school teaching was because I'm still very concerned that a number of my medical colleagues are afraid to tell patients what's really the matter with them. I often will take over a service. I have not been taking care of patients for the last month because of all these travels that Dr. Ross told you about. But I will be starting again next Thursday, and it's not unusual for me to take over patients from a colleague to find that there are 2 or 3 patients on the service who have cancer who have not been told they have cancer. because the physician taking care of them thinks that the patient couldn't bear the burden. It's usually not the patient who can't bear the burden. It's usually the physician who can't bear the burden, who feels that there is nothing more difficult in medicine to do than to talk to a patient about a potentially terminal disease. It's intriguing. The same person who can't say the word cancer to a patient can go in and tell someone that they've got terminal heart disease and that the only option open to them is a heart transplant. But those are obviously sociable, acceptable words. Cancer is not. And AIDS is probably the next issue that's going to have a similar kind of social connotation. I think that's why we find patients who in fact have positive serology for AIDS who still have not been properly instructed by their physicians as to what the consequences of that are. Because physicians don't know how to find the right words to tell the patient. And one of the things that I have found extremely supportive in the hospital environment is a well-informed clergy. I have been very lucky in the 20 years that I've been in practice in the Halifax area to work with some exceptionally capable clergy from every denomination, well-trained in hospital chaplaincy, tremendous supports when some of these hard discussions have to take place. Now, one of the biggest dilemmas that we face in medicine today is what to do when patients' value schemes differ. I've already told you the anecdote of the lady who had the cardiac arrest on November 12, 1979, and the fact, you can see how relevant that is because I've still got the date in my head, and the fact that she's still alive today. But what I didn't tell you was what happened in the first year. She comes from a very simple family. She had grade 7 education, her husband had grade 4. She had 3 brothers and 2 sisters, all of whom had rather comparable levels of education. Now, admittedly, they'd come through the Depression years, but they were simple people. Good people, but simple people. And there had been a falling apart of the family at the time she had married, because she had married someone that the brothers and sisters didn't approve of. And probably of greater importance, she had left her original religion and embraced another religion at the time of her marriage. So in fact, there had been very little communication between this woman and her brothers and sisters until she had her cardiac arrest. And her husband was relatively realistic about what was going on, distraught, as you can well imagine, but relatively realistic. And after this process had gone on for some time, concluded that it was time to use an expression I abhor, but which he used, so I will use it, to pull the plug. And that's what he came and informed us he wanted done. The brothers and sisters, on the other hand, I think in principle opposed anything that he wanted to do, but also were concerned that a long enough period had not elapsed and that medicine was going to find some miraculous cure for her problems, and they did not want the plug pulled. So concerned were they that the plug might be pulled that they in fact went to the Attorney General's Department and indicated that a murder was about to take place at the Victoria General Hospital. Needless to say, as the physician who was supposedly to be the perpetrator of the murder, I was quickly summoned to the Attorney General's Department, and I assured them very carefully that I was not about to do anything of that kind. And the situation went on with this incredible war between family members for over a year, until eventually the VG constituted an ethics committee which took over decision-making, and eventually the matter went to the Canadian courts. And the precedent, because it was the first Canadian precedent, was that it was handled in much the same way as the Karen Ann Quinlan situation in the United States, that is, a legal guardian was appointed who had nothing to do with either side of the family. But here was an example where, because value schemes differed, there was no other mechanism to deal with this other than in the courts. And I want to come back quickly and hasten to tell you that the clergy were incredible in this instance. But even with their support, it wasn't possible to resolve the differences that lay between the two sides of the family. And in that situation, we only resolved the matter by going to court. So when value schemes differ, decision-making can be incredibly difficult. And it no longer really is based on ethical principles, but rather on legal principles. Now, there's another issue in terms of decision-making which is very important and becoming increasingly important to me because I have teenage children, and that is the whole question of parents making decisions on behalf of their children. We're all, or probably most of you, can remember the situation that occurred in BC a number of years ago when the young boy with hydrocephalus was required to have a shunt inserted because there were protests made by the social service individuals, despite the fact that the parents felt they wanted just to allow nature to take its course. And the question of parents functioning as surrogate decision makers for their children has become a very hot topic these days. Do parents of a child who has a malignancy, for example, have the right to take that child out of the healthcare system and to some less acceptable, at least by medical standards, form of healthcare? And I don't have an answer to that. I think that's one of the most difficult decisions that must face any set of parents, and I'm sure it's never made in a light-hearted or easy manner. But what about parents of teenagers? We had a famous example at the IWK also about 10 years ago of a 14-year-old with Hodgkin's disease, which is a form of cancer, which is usually actually well treated with chemotherapy so that these people have a very good prognosis. But this child had watched his parents' marriage fall apart during the course of his illness. Obviously, the stresses and strains of his illness had not been easy ones for the parents to bear. He'd had his hair fall out. He'd missed a year of school. He felt miserable all the time. And he was going to have to go through yet another course of chemotherapy because the disease had reoccurred. And he decided that he didn't want it, that he'd had enough, and he didn't want it anymore. And in that sort of situation, the parents wanted him to have the chemotherapy. The 14-year-old was not in a position legally to make his own decisions. And so the end result was that all kinds of psychiatrists were brought in to try and determine if the child was depressed. All kinds of other people were brought in to try and convince him of the error of his ways. And I have to give him credit. He was not depressed, and he stuck with his principles. And he did not, in the end, take the chemotherapy, and he died. But the question has to be asked, because it was totally and legally permissible. He could have been forced to have the chemotherapy against his wishes because his parents had the legal right to make decisions on his behalf. Is that the right way to do things? And those are the kinds of dilemmas that frequently face physicians, particularly physicians dealing with adolescents, who appear to have the necessary maturity to make their own decisions, but who may and often are in conflict with their parents. And the final problem that I want to bring up is the question of, well, there are more than one problem actually, just flip the cards over, is distinguishing between facts and values. We sometimes get caught up in the details of a case and we can't step back. This is very true for me. I know this happens more than I care to admit. I get so caught up in the facts of the case that I have difficulty distancing myself far enough to be able to really weigh the various values that are involved. It becomes more important for me to get such and such a test done when I've lost sight of whether or not such and such a test is really going to make a heck of a lot of difference to the patient. And I think that that's one of the areas where I have to work a lot myself, and I know my colleagues do as well. Probably one of the most contentious issues that we deal with today in decision-making is the question of scarce resources. We are probably one of the most well-off countries, well, we are, I mean, we're in the group of 7. We're one of the most well-off countries of the world. We have healthcare resources that 95% of all other countries would envy and die to have. But we don't have enough for every conceivable situation that comes along. I've already indicated to you that there have been times when all of the intensive care beds at the Victoria General Hospital were occupied by patients whose prognosis was hopeless or close to hopeless, and it therefore made it very difficult to admit a patient who might have a better prognosis. But there are other examples. We have a finite ability to do heart transplants or liver transplants. These are incredibly expensive procedures. There's no question that they prolong life, but we're talking about bills of $100,000 plus. We're talking about some of the most intensive utilization of healthcare resources that's possible in modern medicine today. It is not possible to give this kind of technology to every patient whose life can be prolonged. And this kind of choices, these kinds of decisions, are increasingly difficult. The healthcare dollars are getting pinched. The Royal Commission will be making its report available sometime in December, and I don't think there's any question that the Royal Commission on Healthcare Resources in the province of Nova Scotia is going to be recommending that some resources are limited even further. And decision-making about who gets those resources then has to be clearly established on ethical principles, but it also has to take into consideration social concerns and legal principles. Let's give you an example. If you look at the top or the most expensive drugs that are used at the Victoria General Hospital today, and I'm using that as an example not because it's the only example, but because it's a very good one, I'll give you the first 2 examples. If a patient presents with an acute heart attack to the VG, we now have a chemical or a drug that many of us call the rotor-rooter of cardiology, which basically just goes in and dissolves the clot right out of the arteries that are blocked around the heart. It's called TPA, and it costs $3,000 per vial. And that's now standard therapy for every new heart attack admitted to hospital. And there are in excess of 40 per month at the VG, and you can calculate roughly the proportionate numbers that would be admitted to your own local hospital. What that drug all by itself has done to health care expenditures is just unbelievable. The next drug, which is incredibly expensive, and you see it in the news all the time because Mr. Vanderzam out in BC has decided he doesn't want to pay for it, is AZT, the drug used in the patients who have AIDS. There is no doubt at all that this drug prolongs life in patients with AIDS. But it costs $1,000 a shot, and the patients need 10 shots in a year, so that's $10,000 a year. Who's going to pay for that? The drug cyclosporin that's used in the management of organ transplants, whether it be kidney transplants or heart transplants or liver transplants, costs $167 a vial, and the average patient needs approximately 5 or 6 vials a month. So these are modern technological changes that are going to impinge on everything else that we do in healthcare because they are so incredibly expensive. So they're scarce resources and we have to ration them, but even to use them for a limited number of patients means we have to ration everything else at the same time if we're going to try and come in with the same size budget or roughly the same size budget that we used last year. So scarce resources is a very contentious issue in decision making these days. Who gets what and when? And the final issue that I just wanted to touch on in terms of death and dying is the question, or decision-making rather, in the patient who's dying, is the question of information given in confidence. I think that's a very difficult problem that all of us have to deal with, but it's particularly true for psychiatrists who are frequently given information that a patient may intend to kill himself or herself, or worse yet, members of their families. What do you do with that information when you know it was given to you in confidence? The decision-making involved in a situation like that is horrendous and agonizing. And I don't have an answer for that particular question. So the whole process of decision-making when dealing with a dying patient is not an easy one. Now, I'm not quite finished, if I can have another word or two, okay? I think there are things that are occurring in medicine which make a big difference. I think that the hospice movement or the palliative care movement has been an incredible step forward. My task these days is to try and convince them that hospice is not equivalent with cancer, but rather should deal with all patients who have terminal illness. And finally, I think patients, I said at the beginning that patients who have an opportunity to prepare for death have a bit of a luxury, and I really do truly think that's true because they can prepare themselves appropriately. But I think everyone has the opportunity to do that, and that they can in fact assure their own mortality, or immortality if you like. If any of you would like to get out your driver's license, you can find an opportunity to preserve your own immortality sitting on the back of your driver's license. In the lower left-hand corner, there's a donor card. And I really want to emphasize to you that if you truly are going to deal with other people's dilemmas in relationship to dying, you must start first with yourself. Give some thought as to whether you would be prepared to donate an organ if something happened to you. Give some thought to whether or not you want to be maintained on life support systems. And most important of all, talk to someone else. Talk to your wife or your husband, talk to your children, talk to your parishioners, talk to people about it. Because the only way we're going to get freed, in quotation marks, of difficult decision-making on a very short interval is to have a prepared population. To have a population who are not asked when they come to the emergency department, do you want to be resuscitated, when they're petrified, but rather have thought long and hard about it at a time like now when they're perfectly healthy and have nothing to fear and nothing to lose by making the decision at this time. And these are some of the issues, I think, that will make our jobs as physicians much easier. To have a prepared population would be my ideal goal. To even have one or two people come in who've thought about it would be marvelous. And this is particularly true for those of you who deal with the elderly. I'm amazed at the number. I've had patients who are 113 years old, who are bright and alert and have no idea what they want done if they should have a cardiac arrest. I can't believe it. They've not thought about these things. But it's an indication of the fact that we're all petrified of death and would think about anything else in preference to thinking about dying. Now I am finished.